All right, we're going to start by filling out where the different drugs come in for anticoagulants. So I want the full diagram of anticoagulants and antiplatelets, uh, antiplatelets, anticoag, and fibrinolytics. So what I want you to do, first step, I want you to draw the clotting cascade. Then I want you to label the where the drugs go, so where their mechanism of action comes in, and then uh, the next part of this is we're going to look at the antiplatelet, which means that we need the platelet activation. Label those drugs. So let me put this correctly. So here's our anticoags. Here's our antiplatelets. And then finally, I want us to label our fibrinolytics. And the challenge I'm going to give you guys is try to keep them all in one picture. So while you guys are working on that, I'm also going to do the same. But I'm going to draw out what the picture looks like, but I'm not going to fill in the drugs. What's goddamn and ... for? Huh? ... Oh, because it's just going to be a lot of work. Yeah, time to draw. Then I want you to draw the chemical structure of every drug. What I will say is that being able to draw the clotting cascade and platelet activation from heart is going to make this exam very, very, very easy. All right. I think I have most of everything. Only thing I am missing is the fibrinolytics. He misses his girlfriend, that's why. All right. So let's talk through all of the different aspects here. Um, First things first, let's go through the anticoagulants. Actually, let's go through the antiplatelet drugs. Yes, yeah. I always end up leaving it off. 7 and 3. Because 7 plus 3 equals 10. That the 3. But all right, so let's talk through the different aspects here. So um there are um a few different ways that the drugs can come in here. Um and what I should have thrown in as well is in here. All right. So let's start with the initial platelet that gets activated. What is the endogenous chemical that fits into the P2Y12 receptor that turns on the initial exactly. So the endogenous chemical that fits inside of the P2Y12 receptor is ADP. So we'll put a green arrow here. And what is our drugs that inhibit the P2Y12 receptor? Right. These are all of our grels. So we have clopidogrel, uh, prasugrel, and just to separate it a little bit, ticagrelor. Now, what is special about ticagrelor compared to clopidogrel and prasugrel? Not a prodrug, and ticagrelor specifically is reversible. Yesterday, we talked about the reason why clopidogrel and prasugrel are prodrugs, that they need to be bioactivated, not necessarily because we expect to, take off an ester, but because we need to take that thio group and make it available for disulfide bonding. So ticagrelor is a reversible drug, whereas clopidogrel and prasugrel are irreversible. You can remember this because we call these our grels. And if grel is at the end of the name, then it's irreversible. But if grel is in the middle of the name, then it's reversible. So one of the drugs that did he give you ticlopidine at all? Maybe. No. Mahana did. Okay. Ticlodipine is kind of an interesting prodrug, but if I was to give you the drug Inagrelor on the exam, then you would say, this would be the kind of question that's like clopidogrel is to prasugrel as Inagrelor is to what? And you would pick ticagrelor because grel being in the middle tells you it's reversible. What does this mean about clopidogrel and prasugrel's kind of efficacy here? How long are they going to last compared to ticagrelor? Much, 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 much longer. So, what is the duration of action of prasugrel and clopidogrel compared to ticagrelor? What is it equal to? Or what is it completely dependent on? The lifetime of what? The lifespan of what? Depends on the lifespan of the platelet, right? So because it's going to be platelets do not have a nucleus, they're not going to be able to create more P2Y12 to recover that dead receptor. So in this case, we're going to be the duration of action of the drug is going to be somewhat closer to the lifespan of the platelet itself. So about 7 to 13 days, I think. Yep, about 7 to 10 days. Great, 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 great. So one of the things that ends up happening is that once the P2Y12 receptor is activated, two things ends up happening. The first is that the cell starts to turn on the turns on the COX enzyme. And what that does is it helps with the release of thromboxane, which helps activate other platelets. But the other thing that ends up getting we create more of is the receptor GB2-3A. So I wrote it over here. So what is the normal ligand for GB2-3A? What normally goes into that receptor? Not fibrinogen. Fibrinogen has to be is a zymogen. Fibrin, exactly. So what goes into this GB receptor is fibrin, and what fibrin does is it acts like the bridge that sticks all these platelets together in that fibrin mesh. So GB2-3A is all about keeping the platelets together and creating the fibrin mesh. So one of the what is the name of the drugs that inhibit this receptor? Which drugs are anti-GB2-3A? Right. Abciximab, uh, and tifrofaban and epitifidipatide. Couple of things to note about these drugs. First of all, the first ones to be created were tirofiban and epitadifitide. What is special about tirofiban and epitadifitide is that they are reversible inhibitors. They're also peptides. Yep. The other thing for abciximab, the way that I always remember it is that we have A, B, C, and then 1, 2, 3. So it's like, oh, I know it's abciximab because of ABC 1, 2, 3 for the receptor. Um, it's just a way that I end up remembering these. But this is the irreversible inhibitor. So again, what would the half-life or the duration of action of abciximab be compared to tirofiban or epatifibatide? About 7 to 10 days. Exactly. Lifespan of the platelets. So we can add that down here. Abciximab. Abciximab. The other thing I want to point out for these drugs as well is what would the reversal agent be for these drugs? So if you've already given the drug, we've already had it stick to the receptor, right? So can we get the drug off of the receptor? Not at all. It's stuck there. It will be there forever. So uh protanamide can work. It can break down some of them, but more specifically, or the better option would be to uh the better option is Indexanet. You're thinking of fondaparinux, I think, if I'm not mistaken. I have to look it up again. The reversal agent is fresh platelets. So one of the things, if you're ever irreversibly inhibiting platelets, the only way that you can recover the drug is by giving new platelets. Now, what would be a situation like this? Well, it would be that someone is at home, they had a stroke, so we put them on clopidogrel, and then they end up having to go in for major surgery very suddenly, so we have to give fresh platelets for them. All right, so that covers our external receptors. What about the COX enzyme? What drug are we going to use as an antiplatelet for the COX enzyme? Aspirin, exactly. Specifically, what is the maximum dose that we should be giving for aspirin in order to have an antiplatelet effect? Maximum dose. Less than 325. What this amounts to, like you guys are pointing out, is that we normally give just 81 milligrams, right? Above 325, we're getting into the anti-fever, anti-pyretic effect. But really, we just want to give less than 325. Can you give aspirin to small children? Can you give aspirin to small children? Not at all. So when we look at aspirin and the specifics about aspirin, couple of big things. Not to children below the ages of 2 years old. Really, you shouldn't be giving it to any child below like 12. What is the danger here? What syndrome are we going to potentially cause? Ray's syndrome. Ray's syndrome is a encephalitic condition where by the drug going to the liver, while someone is infected with a very common virus, normally in adults they can handle it, but in a small child they cannot, and so it results in some severe liver failure, which is not good. Likewise, um, when we talk about aspirin, where? The what are the major adverse effects associated with COX-1 inhibition? Specifically COX-1. Right. So the decrease in mucus production plus the increase in acidity in the stomach means that we can produce ulcers, what is another potential adverse effect of yep, toxicity? 100%. Another one that, of course, is, and this is just an easy win, excessive bleeding, right? We're preventing platelets from doing their job, so it's just an easy thing to stick down. You ever need to pick out a adverse reaction. And then the final one to remember is just all uh, all COX inhibitors, especially NSAIDs, but more so really any of them, is can lead to an acute renal failure. They change the blood flow going into the renal arteries, so it's something that we want to be careful of. All right. Is this helpful, by the way, to go through this diagram like this? If it's not, let me know. Okay. All right. Like I always say, if I'm doing something that you don't think is helpful, let me know. I'm happy to change it up. All right. So let's get into the clotting cascade itself. So in the extrinsic side, we have the combination of 3 and 7 to get 10 to get activated. And on the intrinsic side, we use tenet. So it goes 12, 11, 9, 8, and then 10. I left off one of them by accident. I left off 8. But 12, 11, 9, 8, and then 10. And the goal is to get to factor 10, which slots in with factor 5. And that's what activates it to be able to activate factor 2. What is the other name for factor 2? Starts with an F. T. Sorry. Starts with a T. My bad. Thrombin. Exactly. If there is one factor that you should know its common name as well as its factor name, it's factor 2. So factor 2 is prothrombin, and factor 2A, when it gets activated, is thrombin itself. One of the big aspects of the clotting cascade is antithrombin 3. And antithrombin 3 has 2 major effects. The first is inhibition of factor 10A, and the other is by increasing the action of 2 compounds. What 2 compounds does antithrombin 3 work on? Yes, it does work on thrombin in 10A, but in terms of so that would be one of its major roles. Its other major role is that it activates TPA, tissue plasminogen activator, as well as urokinase. So it has two roles. One is to block the clotting cascade, and the other is to activate fibrinolysis. And as we know, TPA and urokinase will come in and start to convert plasminogen to plasmin. So just to make this extra super duper clear, yes, streptokinase is a recombinant version of it as well. So here's a really nice picture of that just shows. Ignore everything on the right hand side. We don't care about that. But for what I just showed you guys, here we have antithrombin 3, which when it is activated by heparin, has two major roles. The first role is inhibiting factor 10 and factor 2, so factor 10 and thrombin. And the second major role is to activate TPA as well as urokinase. Urokinase and TPA, their job is to change plasminogen into plasmin. And by doing that, we're going to be able to break down the fibrin clot. So plasmin's role is to degrade the fibrin, the fibrin mesh. Heparin does both. So in order for antithrombin, the cofactor or the activating factor for antithrombin 3 is heparin itself. So in order for it to do its job, either one, it needs heparin to get involved. Good question. Feel free to take a picture of this as well, if you'd like. All right. So, which drug that we just talked about activates antithrombin 3? Heparin, exactly. What else? What else can activate? Low molecular weight heparin. Maybe not. Can that go in there? Yeah, it does, right? Am I crazy? Yeah. Low molecular weight heparin, and then also synthetic heparin, which, as we've gone over, is fondaparinux. Right. So whereas heparin works on factor 10 and 2, low molecular weight only works on factor 10, and synthetic heparin only works on factor 10 as well. All right. Let's talk through some big aspects of the different kinds of heparins. So we know, as we just talked about, heparin is primarily working on factor 10A and 2A, whereas the other two are working primarily on factor 10. What is the reversal agent for heparin? Protamine sulfate. Exactly. Very nice. How about for low molecular weight heparin? What would be the antidote in this case? Same thing. So the only difference between low molecular weight heparin and heparin is that we just spun it very, very quickly and took the smaller bits. So that means we only get a partial response because the smaller a heparin is not able to wrap around protamine as well. And then finally, what is our reversal agent for fondaparinux? Officially, it's something called APCC, which is activated prothrombin complex. So essentially what we're doing is we're giving factor 2A. So we're bypassing the inhibition of 10 by just giving 2 is the way to do it. All right. And then finally, just some let's go back to our diagram and we'll come back. We also have a pair of drugs that directly inhibit thrombin. And what are those drugs? Are direct thrombin inhibitors. All good. These would be things like, in terms of our IV agents, we have our argatroban, decirutin, and then for our oral agent, we have dabigatran. Exactly. Fitting those into our groups here. So we have our direct thrombin inhibitors. Which are going to be working, of course, on 2A. And our reversal agents here are the same thing, right? We're going to give APCC, so the activated factor 2A, or for dabigatran specifically, we can give a reversal agent called idirucizumab. Idirucizumab for dabigatran. Exactly. Yep. All right. Just quickly, let's talk about some adverse reactions. For heparin, what are some adverse reactions that we should watch out for? Definitely bleeding. Yep, 100%. And then HIT. Exactly. So osteoporosis. Yep, 100%. Yep, hyperkalemia. Also, lots of drug interactions with anything that can the uh, the drug interactions what's it called, with anything that can increase bleeding, right? Aspirin, clopidogrel, all that sort of stuff. When we talk about heparin induced thrombocytopenia, what are we talking about here? What is this thing? not formation of a clot. Yeah. So thrombocytes are our platelets. And whenever you see the word penia, this is talking about a decrease. So we're talking about a significant decrease of platelets because of heparin. Right. So what ends up happening here is that um, the drop in platelets that it how do I want to say this? It it comes in kind of two stages. The first stage is that you have a significant drop in platelets, and that's going to be for about 5 to 10 days. What ends up happening is that after that uh, amount of time, the body creates antibodies that are platelet activating. And of course, this increases the risk of a clot. So, what ends up happening is that we get someone through the initial clot, but what we have to do is we have to watch them to make sure that they don't suddenly, after a couple of days, develop this thrombocytopenia. Exactly. Right. Um, what this can result in is, you can have clotting in the skin, which is that purpura that we talked about previously. You can have clotting that causes skin necrosis. You can have arterial clots. You can have venous clots. You can have strokes. You can have heart attacks. You can have tons and tons and tons of different stuff. And essentially, what the risks are is you have you know the clot can be any kind of clot that we talked about: stroke, DVT, PE, anywhere in the body. Exactly. Yep. Um, what is the way to avoid uh, HIT? What should we do if we need to give someone an anticoagulant? How should we do it instead? What's a better drug? In this case, it would be the low molecular weight heparin. Yeah. So it's about a 10 to 1 difference. So someone has a 10 times less chance of developing HIT, and even lower for the synthetic heparin as well. All right, sweet. Um, all right. Uh, let's talk about uh other drugs that inhibit factor 10. So what are other drugs that work on factor 10? Right. These would be our DOACs. Apixaban, Viroxaban, Adoxaban, all those good fun ones. Um, this is where we talked about earlier the reversal agent. So reversal is andexanet. Kind of a couple of big ones. Um, the da, da, da. That's really all I want to say for that for now. Yes. Yep. Sorry. I should say that. Apixaban and rivaroxaban are only in Dexanet. Yep. Which is funny because the more common one is apixaban, but it doesn't have a reversal. Which means if someone is on apixaban, what should we give them to reverse apixaban? APCC, right? Because it avoids factor 10. So we just go into the next step of the cascade. Sorry, if they were on edoxaban, my bad. I'm getting all confused. If they're on the one that's not covered by Indexinet, or if Indexinet is not available because it's just extremely expensive. Stuff like that. Sorry. All right. Finally, let's talk about the fibrinolytics. So what are some of the fibrinolytics that we can give someone? What are the kind of the big ones? So in terms of fibrinolysis, what we're going to be doing is fibrinolysis is all about increasing the action of plasmin, right? Exactly. Yep. So one of the things that we can do is we can uh, give the agents that cause plasmin to be created. So all of these are going to be things like we can give TPA directly, or we can give recombinant versions of TPA, which would be all of your alteplases, your tenecteplase, your gravidipase, I think. I can't remember. But you also have your non-fibrin specific agents, which would be your urokinase and your streptokinase. Which, by the way, do you guys remember from when you went through the different kinds of bacteria and you learned about group A hemolytic bacteria? That's how they're hemolytic. This is how they break down blood, is by using streptokinase, which is created from streptococci. So when you talk about the bacteria that breaks down, like causes sore throat, stuff like that, they're using an enzyme to cause your body to break down, you know, plasminogen into plasmin, which messes with your blood. All right. Any questions about this diagram at all? Streptokinase is created from streptococci, which is the cause of, a common cause of strep throat. All right, let's talk through monitoring real quick. Did he talk about monitoring like PT and PTT and INR and all that kind of stuff? Kind of? Okay. When we talk through monitoring, the biggest thing is we're talking about the um, the three different values. So we're either talking about PT, which is the prothrombin time. We're talking about PTT, which is partial thromboplastin time, or we're talking about INR. So what these are is prothrombin time is the PTT is what affects the intrinsic pathway, whereas PT is a factor of the extrinsic pathway as well as INR. So when we go through the different drugs, we can see exactly how different, well, let's talk about how the different ones end up doing it. So what I'm going to do, just because they're the same, and the factors that affect PT and INR, or what increase their levels, is any sort of vitamin K deficiency, and then specifically factor 7. Factor 7? Yes. Factor 7? Am I crazy? I don't. Maybe this is more than what you guys have to know, because I think you go over this next year, but I don't think you have to know that for this one. Okay, he only wants you to know INR. All right, then that's where we'll leave it. PTT for heparin. Okay. That's where we'll leave it then, because I don't want to go into something that we don't have to worry about it. All right. Let us go into the next thing. Did he put? I don't think glaucoma is on this exam. Uh, what I am trying to pull up is do. Here it is. Actually, give me 1 second. I'll be back in 2 minutes. Boop, boop, boop. Nope. God. All right. So one of the things I wanted to do was talk about exam 2 and 3. So if I know there's one topic that's going to be on the exam that is going to be overly confusing, is talk about alpha and beta, right? Alpha 1, alpha 2, beta 1, beta 2. So it's been a while. So I thought it would be good for us to go back through and do some comparisons of different stuff. What I am actually going to do. Oops, sorry. What is I just want to give myself some more room. That's what makes me a great tutor, right? I'm always thinking about what you need. All right. What I want you to do is I want you to also fill in, as you go down this list, the class and the mechanism of action. Do we want to go through this together for the first couple of ones, or do you guys want to try to do this on your own first? What works better for you? Together? Okay. That'd probably be a better use of our time. You also have to remind me if these drugs are on your list or not, because I went by my list that he gave us, and I'm pretty sure some of them are not. I want to skip phenylethylamine first. What we are going to do . is, let's start with epinephrine. So what class of drugs does epinephrine fall into? Don't overthink it. Yeah, right. So this would just be, we could say that it's endogenous ligand, right? Or we know that based on the power of being, epinephrine would be mainly beta with some some alpha activity, but for the most part, it's mostly just endogenous. And like we just talked about, mainly beta activity over alpha. Same thing with norepi. It's an endogenous ligand, and it has the reverse, mainly alpha over beta. So going by our main clinical uses, do we use, can epinephrine be used in allergic reactions? So for column A, for allergy. Yeah, 100%, right? EpiPens, huge part of reversing allergies. What about norepinephrine? Not at all, right? And maybe it would be helpful for us to list, just to go back through and talk about the different aspects of the receptors. So for beta 2, what we care about in beta 2 is that it is a GQ GPCR. And whenever we see GQ, what should we automatically think of? What kind of tissue in the body? Calcium, and the tissue would be smooth muscle contraction, which is of course mediated by calcium, right? So where are the different sites that we tend to see beta 2? It would be places where we would want smooth muscle contraction, right? So we would see this in the blood vessels. Where else? Where else do we see beta 2? Not really the heart. In the heart? Mm, not really the heart, I would say. Bladder, yep. So the detrusor muscle, the lung, 100%. You're thinking beta 1 for the heart. Because we have two lungs, beta 2, two lungs. We have one heart, beta 1. That's how I always think of it. Also, we have things like um, in the eye, right? We can use some beta drugs for the eye. And what's the effect of the beta drugs? What specific tissue in the eye? Is it going to be the ciliary body, or are we talking about the muscles? Yeah, exactly. Aqueous humor production. And then finally, what about glucose? What's the effect? What tissues are affected that are about glucose when we talk about beta 2? Skeletal muscle? Yep. Skeletal muscle. You're very close. Liver. Very good. Hepatocytes. Yep. So when we talk about the agonism, so agonism of might be helpful for me to do it more like this. So when we talk about beta 2, what's the effect of agonizing beta 2? Do we get vasoconstriction, vasodilation? Vasodilation, right? So we are GQ, which means that we have contraction. And in this case, what we're doing is we're contracting the smooth muscle, which is surrounding the blood vessel. And this is pulling it outwards. So we're contracting it outwards, which means that we end up with vasodilation. Which means what would be the effect of the antagonism? Vasoconstriction. How about in the bronchi? What's the effect on the bronchi? Things like albuterol. Yeah, same sort of thing. Bronchodilation. Again, we're doing the contraction, which is going to pull those, uh, pull the bronchospace wider, whereas antagonism, we're going to get bronchoconstriction. In the uterus, we get tocolysis, which means that we stop contractions because we are uh, um, uh, preventing the rhythmic contraction. In the skeletal muscle, we increase glycogenolysis. So this means that the skeletal muscle is breaking down glycogen, whereas in the liver, we're doing glycogenolysis. So glycogen stores in the liver are being broken down, as well as gluconeogenesis. So what this means is that both the skeletal muscle and the liver are breaking down the storage of sugar, and the liver is making new sugar. And the result of that is that we get more and more sugar being dumped into the blood. In fat cells, we have more lipid release. And then finally, in the ciliary body, we have aqueous humor production. Is this helpful, by the way, to go through these like this? Okay, good, good. Let's talk about some drugs. Oops. So, what are some of our beta 1 selective agonists? Sorry, beta 2 selective agonists, because we're talking about beta 2 right now. What are some beta 2 agonists you remember? Albuterol, very nice. Albuterol, we can have the levo version of it, levalbuterol. Salmeterol, yep. Vilanterol, formoterol. And then the only one that doesn't fit is terbutaline. Very nice. How about our beta 2 selective antagonists? So which are selective antagonists for beta 2? No drugs. How come? Why are there no selective beta 2 antagonists? Exactly. This would just make it harder to breathe, right? No benefit. Great. Great, great, great. Let's go through and let's talk about beta 1 then. What is beta 1 uh, conjugated with? What kind of GPCR is it? Mm, so beta 1 is all about getting the heart to start doing its stuff. So if beta 2 is all about GQ, which is contraction, beta 1 is all about revving up the heart. And so in order to rev up the heart and get the muscle to do what it needs to do, are we going to inhibit stuff or are we going to stimulate stuff? What do we think? Stimulate. Exactly. So beta 1 is GS GPCR. And so when we agonize beta 1, so when we turn it on, what do we expect the heart rate to do? Increase. Same with contractility. Same with automaticity. What I'm going to do. Whoop. All of these increase. What do we call, what's the specific vocab word for heart rate? What's that word? Chronotropy. Very nice. Contractility, which is the force of contraction, is inotropy. And then finally, automaticity is dromotropy. What about renin release? Do we release more or less renin when we activate beta 1? Way more. Tons more. Right? And then all of this accumulates in what? Are we going to have more or less blood pressure? More. Very nice. Antagonism, of course, is the opposite of all of these. All right. Let's go back to our drug list. And what is our only beta 1 selective drug? Dobutamine. Very, very nice. And then how about our non-selective beta agonist? Which one was our non-selective one? I'll tell you, it starts with an I. You're very close, with propanol. Isoproterenol. Very nice. And then when we talk about our non-selective versus our selective, so some people love to point out man baba. And is man baba selective or non-selective? Selective, right? So metoprolol, atributalol, nadolol, uh, uh, no, the bivalol, I think, bisoprolol, pataxolol. Yeah, the bivalol. Is it man baba or man babe? I can't remember what the actual acronym is. Man babe. Esmolol. Right. And then of course our non-selective are the non-mom man babe ones, right? So we have things like propranolol, nadolol, pindolol, sotalol, timolol. Where is timolol specifically used? Do we use it for the heart or do we use it somewhere else? Eye drops, right? So we're using this for glaucoma. So we're specifically using it for its beta antagonistic activity. All right. Do we want to do alpha or do we want to start filling out this chart? What works better for you guys? Has this been helpful, by the way, to do this? Okay. All right. I had a feeling you would like these charts. The oops. All right. So this is all about alpha. So first of all, alpha 1, is this GS, GI, or GQ coupled? GQ, very nice. And so whenever we think about GQ, we should think contraction. And then how about alpha 2? GI, which we know is all about turning off alpha 1 as well as everything else, right? So we have a bunch of different places that we can find alpha 1 and alpha 2. And often we find them in very, very, very similar areas. So in terms of activating the vascular smooth muscle, what is the effect here? Or actually, maybe it would be better. No, we'll talk about this. Exactly. Vasoconstriction. So what is the therapeutic use here? Why would we want to vasoconstrict? Hypotension and shock. Exactly. So we're using our alpha 1 agonists in order to raise blood pressure quickly. That's where the benefit of them comes from. How about in the prostate and urethral smooth muscle? What's the effect of activating there? Constriction. Yep. So we have smooth muscle constriction. So unlike beta, which when we contract and it dilates by moving things apart, alpha contracts and brings things closer together because of the way that it's positioned. So we're going to be constricting the prostate, making the urethral diameter smaller. So is there any therapeutic use for making the the urethral diameter smaller, or making the prostate squeeze the urethra even more? No use. And it's a good question about incontinence, especially with things like overactive bladder. But in cases like that, the issue is more to do with the detrusor muscle or with the sphincter coming out of the bladder. So instead of, treating the symptom, what we want to do is treat the cause. So that's where we would go towards more of a muscarinic drug rather than working on alpha. How about in the radial muscle? Here, we're going to get pupillary dilation. Which means that we're going to be opening up the eye, which is useful for things like a retinal exam. And then finally, in the nasal mucosa and the surface skin mucosa, what is going to happen to those blood vessels? Are we going to constrict them, or are we going to dilate them? Constrict. So for the nasal mucosa, what use could we have in vasoconstricting the blood vessels, specifically in the nose? Nasal congestion. And then for surface skin blood vessels, I want you to think about the face. And what would be the benefit of constricting blood vessels in the face? You're very, very close. And I like the way you're thinking. Rosacea. Sweating would be muscarinic drug. All right. So in terms of our alpha-1 agonists, what are some of the alpha-1 agonists that we remember? Sudafed. Yep, 100%. Oxymetazoline. Both of them used for their nasal congestion. Phenylephrine. Yep. Which is now pulled from the market. Phenylalanine. Phenylalanine? And then there's one more. Starts with an M. MI. Oh, okay. MID. Midazolam. Midodrine. Right? Take it 3 times a day. Usually used for orthostatic hypotension. Midodrine. All right. Just to quickly go through these, inhibiting the vascular smooth muscle through alpha-1 is going to give us vasodilation. Here we're going to have smooth muscle dilation. We're going to have pupillary constriction. Then we have vasodilation here. So what would be the benefit of using a alpha-1 antagonist in terms of vasodilating blood vessels? What would be the benefit here? Why would we want? Yeah, exactly. Hypertension, as well as erectile dysfunction as well. How about in terms of for the prostate and urethra? What would be the benefit in dilating BPH 100%. And there's no uses for these other ones. No accepted uses. So we have our alpha 1 antagonists. And specifically, we have to divide these into our non-selective, which is 1A and 1B, and our selective, which is just 1A. So first of all, oh, kidney stones. Yep, that would be the other one. Dim light reading. Yeah, so that would make sense. So when we talk about the vasoconstriction, so alpha 1, sorry, causing pupil constriction, sorry, pupillary dilation. What this is going to do is it's going to take your pupil and it's going to make it larger. And a larger pupil can take in more light. So if you use something like prazosin, then that means that in dim light, you're not able to accommodate for the lack of light and make your pupil get larger. So prazosin would be a bad choice for someone who has to, who's a night driver, for example, or is maybe like a night guard. So where do we find 1A? Where's 1A specifically found? Muscarinic wouldn't be a bad idea. 1A is the prostate, and 1B is our blood vessels. Yep, you switched them. So in terms of our non-selective guys, our non-selective is PTD, prazosin, terazosin, doxazosin. Prazosin, terazosin, doxazosin. And our selective is AST, which is alfusilin, silodosin, and tamsulosin. All right. For our alpha 2, alpha 2 is all about turning off the other receptors, right? So where we're specifically using these is for specific effects on the different other receptors. So for alpha 1, we're using a alpha agonist in order to turn off alpha 1. So decrease alpha 1, which gives us, it's kind of a bad color. Let's try this. Decrease alpha 1, which gives us vasodilation. What would be the effect of turning off beta 1? What's the main effect we're going to have? On what kind of tissue or organ? Here, in this case, it would be decreasing heart rate, right? Decreasing force of contraction, decreasing dromotropy. And so the therapeutic use in this case would be for hypertension. Same thing here. By turning on alpha 2, we're going to be turning down aqueous humor production. And by turning off beta 2, we're also going to be turning down aqueous humor production. So 2 different ways of doing it, and the therapeutic use would be glaucoma. So we have a couple of drugs. Does anybody remember one of the drugs that we use? Yeah, brimonidine, clonidine, guanfacine, lofexidine, brimonidine, and then there's just one that doesn't follow the rule, and that's methyl dopa. It's the only one that doesn't. Do we have any alpha 2 inhibitors? No, there are no alpha 2 inhibitors. It would not be beneficial. All right. Yes, there are non-selective ones. Phentolamine. There's also the what is it? Labetalol, carvedilol, which is alpha 1, beta 2 antagonist. But we could actually go through those right now. So let's go back up to this chart. So epinephrine, as we talked about earlier, is mainly beta, right? And so beta, as we talked about, in the beta 2 receptors, we're going to get vasodilation. And in the beta 2 is going to give us lots of smooth muscle contraction, whereas beta 1 is going to speed up the heart. So the vasodilation is what is beneficial in terms of the epinephrine here, in terms of allergic reaction. How about in terms of nasal decongestion? Could we use something like epinephrine if someone had severe nasal congestion? Not really, no. What about as a pressor? So raising blood pressure around the body? Yes, 100%. Epinephrine is a pressor, can be used for pressing. What about as a local vasoconstrictor? Think anesthesia. What is usually injected along with anesthesia? Lidocaine and epinephrine. Yeah. So what's the purpose of epinephrine when we do the lidocaine? Right. So by using the epinephrine with the lidocaine, we're vasoconstricting in that specific area. And one that's going to cut down on bleeding. And the other is that it's going to keep the drug in the area, right? So it's going to stop the lidocaine from leaching out and being, swept away by the bloodstream. How about bronchodilator? Would epinephrine have an effect on bronchodilation? Yeah, which is one of the effects that we can see it happening, especially like asthma, not asthma, with allergic reactions, right? Someone's throat is swelling shut. And then increasing cardiac action. Will epinephrine increase cardiac action? Yes, 100% through beta 1. Looking at norepi, which is mainly alpha, can norepi be used, let's say, as a pressor? Can we use norepi as a pressor? 100%. Will norepinephrine increase cardiac action? Yeah, it will. Why? Because what's going to end up happening is that we're going to uh the well, we can actually go down here. We can see it. That through the vasoconstriction, what we're going to end up doing is we're going to increase cardiac output, right? By alleviating some of that pressure for the heart to raise the blood pressure. And that's really the only two effects. Just to skip to some of these other ones. Let's go through and let's talk about all the different. That's all screwed up. Yeah, these don't. Oh, because they're. Yeah, those are all screwed up. What are our other pressors that we remember? Which ones are the other ones that are used as pressors? In general, yeah. Or especially on our list as well. Droxidopa, yep, big pressor. Dobutamine, right? Because it's going to be working on the heart to increase heart rate, increase force of contraction. Let me find one thing. Oops. Maybe this would be phentolamine. Yep. Is that on this list? Should be on this list. No, but that's a really good one to have on here. Oh, here, it's right here. All right. What I'm going to do is I believe this is already posted on the classroom. But just so you guys make sure that you have it, here is the link to this document. Oops, nope. Sorry, do that one. Here's the link to this document. It has, just to show you, it has everything that you would want to know about exam 2 and 3 stuff, right? So it has all the comparisons of alpha and beta. It breaks down all of the different drugs, what they do, what they're used for. Here's all those different charts that we were doing just now, right? Where we talked through all the different stuff. If you notice anything that's missing or that's wrong, let me know. Oops, I'm going to delete that. And then on the last page is the main clinical uses thing, which is a really, really good study tool. And I think if you can go through this and kind of understand the answers, you're in a good place for exam 2 and 3, right? You don't have to necessarily worry about the uh, the um, uh, like don't go overboard with the comparisons, right? You were already tested on this information, so you don't have to go super in depth with them. So with that in mind, let's wrap up here. Just so you guys can go study for Druglet. I will put a link to this online. And if you have any questions, let me know. Yes, same time tomorrow. Yep.